All. This is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So the discussion today is about the study from Israel. This is by Professor Dr. Eli Schwartz and his team members. This study is for outpatient patients who were isolated in hotel rooms in Israel, and they were then managed with some of them with ivermectin, and this is that study. So let's start our discussion. What we'll do is this. We will first look at the summary of the results so that the cool beans who just want to understand quickly what is going on, they can see that. And after that, we will actually go through the study itself. The reason I would like you to focus on this study is that there is a lot of criticism of the studies for ivermectin. And I'll let me show the results first, and then I'll give you some more context at why do I feel good about this study. So here, these are our gifts continuing. And here, if I spilled the beans, here is what these are. So this is the important part, and I have the links in the description. In a multivariable logistic regression model, the odds of a negative test, at day 6 was 2.62 or were 2.62 times higher in the ivermectin group. So the odds of a negative test from COVID in the group that was taking ivermectin was 2.62 times. This is not 2.62%. This is 2.62 times higher. That was significant. So if you see here, the confidence interval is 1.06 to 6.45, which is the range. It could be 1.06 times higher, or it could be 6 times higher, 6.45. But important thing is it does not cross unity here. It is on the one side of the unity. That means it is significant. The other significant result is that cultures at days 2 to 6 were positive in 13% of ivermectin, people who were taking ivermectin, versus 48.2% in placebo. And look at the p-value, 0.008, again significant. So what are they saying here? What they're saying is when you use ivermectin, then the viral clearance is increased in ivermectin group, and the shedding is reduced in the ivermectin group. Of course, if the clearance has increased, then the shedding has reduced. And this is the statistically significant outcome. Conclusion, there were significantly lower viral loads and viable cultures in the ivermectin group, which could lead to shortening isolation time in these patients. And I would go over a more detailed discussion that they have, and I want to discuss some of their responses to the criticism about ivermectin studies. And then we would look at their own studies, strengths and weaknesses as well. But this is the beans. We have spilled the beans here. I am actually going to request Dr. Eli Schwartz, Professor Dr. Eli Schwartz, to come join us as well and discuss a little more about the study. Another important point in the summary is that this study is for outpatient patients, and they say in their paper that this cannot be applied to hospitalized patients, so that would need a separate study. Still, within the outpatient patient studies, this I think is a good study, very good study. So good job on their end. So now let's go over the study. I have the paper here as well. I would love if at some point you can go over this paper as well and just kind of look at the work that they have done. It's a good work done. And at the same time, let me very quickly show you my piece of art. So I had shown this before as well, but I just love this painting so much that I wanted to show it to you once more. So here is my painting of drums, or classical Asian drums. And now let's continue with our study. And there is a super chat, so thank you very much. So study, here is what it is. It is a double-blind study. I almost wish that we can go over every single ivermectin study, look at their strengths and weaknesses to see why did WHO reject some of them and keep some of them, and what is really going on. It seems like there are 26 or more studies, So it seems like a lot of days to spend on it. Maybe with the regular talks, maybe we should have daily half an hour to do studies as well, one study a day. What do you think? So it is a double-blind study, randomized, placebo-controlled. It is small, and they say that it is small, but again, even when it is small, they had looked at the power they needed, so statistical power they needed to make the results significant, and there was a minimum number of people to be in the study to reach that power, and they had tried to get that minimum number. So it is small. It is an outpatient study, so not for the hospitalized patients. It is for early COVID, mild to moderate. And their primary endpoint was reduction in viral shedding. Let's see. Population, the folks who were taking part in it. So once again, these were the people who were RT-PCR positive, were in isolation in various hotels in, I believe, Jerusalem and one more city. What was the inclusion criteria? They had people who were greater than or equal to 18 years of age, who were not pregnant, who were RT-PCR positive, and already were in isolation. They excluded people who were lesser than 40 kilograms of age, younger, or too weak, who were allergic to ivermectin, of course, who were unable to take oral meds. And there are people who sometimes say that, hey, I cannot take oral med, I just psychologically or generally. Participant in other randomized control trials for COVID, so they were already participant in something, and then had the RT-PCR positive with a cycle threshold of greater than 35, meaning already there, and then high-risk patient. They did include some high-risk patient in here as well, but mostly they would exclude high-risk patient because the study was for outpatient. They were not looking to study those who would be hospitalized. The reason for that is very simple. If somebody is today sick and there is a chance for them to become severe, then they had to follow them in the hospital as well and continue the treatment there, and hospital may not allow it for their own protocols. So they just very strictly adhered to the protocol that could be done successfully, and that was in the outpatient. What was the intervention? What did they do? So here is what happened. The study was from May 15th to January 2021, end of January 2021. There were total of 89 people. They actually assessed 110 people. Out of them, 110 eligible people were 89 who participated. Ivermectin group had 47 people. 17% had comorbidities. Placebo group had 42 people and 9.5% had comorbidities. Again, this was not statistically, this difference, you can look at that and say, well, there were lesser people with comorbidities in the placebo and more in the intervention arm, but still this was not statistically significant. So let's say one person versus two people. Median time for symptoms onset for these patients was 4 days. Median age of the patients was 35. Range of age was 20 year to 71 year. 22.4% were equal or greater than 50 years of age. 7.8% were equal or greater than 60 years of age. 13.5% had comorbidities, although they had excluded some with the comorbidities which would cause a risk to go to the hospital, but still they did include folks, 13.5%, which had comorbidities. 83% were symptomatic. The remaining were asymptomatic. So this was the structure. The dose, they administered dose by kilogram, but instead of just measuring kilogram for everyone, what they did was this: 40 kilogram to 69. Remember, lesser than 40 were excluded. 40 to 69, they gave them 12 milligram. So I think the tablets there were 3 milligram each, so 4 tablets. And greater than 70 kilogram, more than 70 kilogram or equal to 70 kilogram, they gave them 15 milligrams, so 5 tablets. This is interesting. They treated them for 3 consecutive days. So this is very different from the way I started treating, and that was 5 days and onwards. I actually would continue till the patient recovers. FLCCC had said 5 days. Here we are looking at 3 days. Many of the studies actually did 1 day, day 1, then day 3, and that's about it. I think I was the most aggressive, that I would just continue giving ivermectin till the patient said my oxygen is fine, my symptoms are fine, and I'm good. So after me, the second most aggressive, I believe, were FLCCC, 5 days continuous. And after that, there were many who would give it for 2 days, 1 day, third day, 1 day, fifth day, and so on. Here we are seeing 3 days. And these 3 days are consecutive. And the drug was given, ivermectin was given 1 hour before meal. So this was not with meal, which actually can increase the bioavailability. This is without meal. And please realize this, that in textbooks and in studies, generally ivermectin is recommended separated from meal so that it can stay in GIT more. So this structure here is more towards that recommendation in literature. Now on the placebo side, same number of pills were given, same appearance of the pills, and the same adherence, that here take it before the 1 hour before. I just want to make sure that everything is fine here. Okay, continuing. So that was the dosage. It is interesting to see the number of days, very different from what I have been doing. Testing. So now their point was, if we administered ivermectin, will a person shed less? That means their viral load is going down faster. So here is what they did. On day 1, when the therapy would be initiated, they will take a test, RT-PCR test. Then they would give the medicine for 3 days. So day 1, 2, and 3. Then from 6th day onwards, every second day they would test. The 6th day was their milestone to say that on the 6th day, what is the difference between the two groups? But anyways, they continued to test after the 6th day as well, every other day. So 6th day, 8th day, 10th, and so on, up till the 14th day. So first 3 days, you get the medicine, but then you are tested on the first day, and then from 6th to 14 every other day. That is how the folks are being tested. They discuss in their paper that we wanted to make sure that the tests are uniform, so the same one lab was used for the testing. And similarly, they also wanted to make sure that the the testing staff, the one that is working with the nasopharyngeal swabs, that was also uniform in their operation, in their method, so that there is not too much variation, that somebody touched it lightly versus somebody else touched it with more force. So they had a small staff intentionally, so that there are less people and they all are doing similar, and they were trained for this testing. There is one more important thing, and how did they decide that who is negative? So cycle threshold, if they would get the viral copies at the cycle threshold greater than C30, then they would say that this is negative. So this was actually a stricter criteria. And then what they were looking was 34,000 or lesser viral copies were taken as a negative test. So if in my nasopharyngeal area, they did the swab, and the RT-PCR was done up to 30 cycles, and the number of copies for the virus or the RNA were 34,000 or lesser, then it was supposed to be a negative test. Now, what are the results? This is what would excite you. I'm sure this would excite you. So look at this. This table is also in their paper. This is table number 2. So if I go all the way down here they have tables. This is table 1, baseline study population and the characteristics of it. Males were more, females were less, and so on. And then down here, this is the table number 2. This is the table that I have it here as well. So you can look at this table, or you can just see it with me. In this table, The most important line is the day 6 line. The other lines are interesting, but the most important is the day 6. So let me just very quickly also show you. Let's start from day 4. On the day 4, the number of people who were still giving the test and working were 50. So they were a smaller population. And the second thing is, on day 4, at least for their primary endpoint, the results were not significant. So if you look at the p-value, it is 0.12, it is not 0.05. So it was not significant, and they actually do not use this either. The other insignificance, if you see here, is that the confidence interval is crossing the identity as well. Anyways, they don't use day 4, they use day 6. On day 6, then they had reached the number of people 89, and they had 89 from then onwards. On the ivermectin side, people who had less shedding, or people who were shedding lesser, who had improved 72%. So 34 out of 47. And in here, 21 out of 42. So 50% had improved here, and 72% had improved here. So that is important. And the p-value is significant, and the confidence interval is significant. If you see 0.03, and here 1.09 to 6.31. The other interesting thing is the odds ratio, 2.62 times. So that is what odds of negative test on day 6 for people who are taking ivermectin is 2.62 times higher than those who are not taking ivermectin. Beautiful. And then they have results for day 8 and 10 as well. Another thing that is really important is between day 2 to 6, the ivermectin versus placebo, the culture of the virus. So let's say we have one group who we are taking the nasopharyngeal swab, and we are doing RT-PCR. RT-PCR doesn't tell you if this is a viable virus. It just says RNA of the virus, piece of the RNA of the virus detected or not. It doesn't say the live virus. By live, I mean viable virus or not viable virus, and so on. So what they did was, afterwards, they went back to those swabs, and they did a test in the BSL-3 and above lab to check, I think BSL-3 lab, to see if there were viable viruses in there. So virus culture, not the RNA detection. And what they found was, so this is day 2 to 6. Keep in mind the Cali study as well, which said at day 2, 95 to 99% reduction in virus. So here, ivermectin, day 2 to 6, 13% people had the virus, versus placebo, 48% people had the virus, viable virus. Beautiful. And p-value is 0.08, 0.008. So significant. So I love it. This is awesome. Adverse effects. What did they see? They saw 2 types of adverse effects, diarrhea and rash. Diarrhea was 2 people in ivermectin group had diarrhea resolved in 2 days, 3.5%, and 1 person in placebo group also developed diarrhea resolved in 2 days, 1.7%. Rash, nothing in the ivermectin group, 2 people in placebo group had a rash which also resolved within 2 days. So this is the study. I love the study. And I want to show you now some parts of the discussion which are interesting. So of course, you can download the PDF and read it, but I want to show some pieces that were interesting for me. So here is the discussion. In this double-blind randomized trial with mild COVID-19 patients, ivermectin significantly is used from a statistical point of view, reduced time of viral shedding and affected viral viability when initiated at the first week after evidence of infection. This is a very important statement. Our primary endpoint was to show the benefit of ivermectin on day 6, 3 days after ending the treatment. So remember, the treatment was day 1, 2, and 3, which was achieved with 72% of samples being non-infectious. 72% people had become cleared by day 6, and they were only given ivermectin for 3 days, in comparison to 50% among placebo group. Odds ratio 2.6. And then Even at day 4, 1 day after treatment ended, the ivermectin group showed an odds ratio of 2.4, although it did not reach significance. Now I want to read this as well. The results show the advantage of ivermectin where only 13% of samples stayed positive on day 2 to 6. Viable virus only in 13% of the people, while 48% placebo had viable virus in this time. This is a huge difference. And remember the p-value 0.008? That is awesome. Imagine this is not only shortening of the stay. I mean, they have to be very objective here. They cannot stretch this so that somebody is going to come in and say, you know what, I object about your speculation here. So they are very, very objective, but I can stretch it and say, if you can reduce the viral load so rapidly, not only you're going to get the patient out of the COVID state, you are going to prevent long hauler. You are going to prevent a severe disease. You're going to prevent death for them. This is what Dr. Hector Carvalho was talking about that day, that long hauler does not occur if you are treating with ivermectin. And this is what I have been crying about and making noises about from the very first day, early aggressive treatment. Look at this. This is early aggressive treatment. Believe me, if today the whole world said, we're just going to give ivermectin, the pandemic will become just a nuisance. Okay. A major criticism, so I want to continue some more discussion. A major criticism regarding this in vitro model. So they're talking about the Cali study. Remember the Cali study from Australia, he had said he had used ivermectin dose that was supposed to be so high that people, WHO and FDAs and others have been using, and doctors have been using this to say, well, that dose is so high that you cannot give it to people who are alive, their cells would die. So here, they're talking about that study. So if you see, start from here, line number 215, the broad spectrum antiviral activity of ivermectin is related to its ability to target the host protein alpha and beta 1. I think the concept of antiviral here is not the best, in my opinion. It should have been virustatic instead of virucidal. But antiviral is a more open statement. It just is against the virus. It could be virustatic as well. So if I was there, I would have put virustatic behavior. And what that is the important alpha and beta 1. And remember, we actually see that there are 5 various mechanisms. And then they talk about the antiviral properties of ivermectin against SARS-CoV-2 was shown in an in vitro model. So this is the Cali study. A major criticism regarding this in vitro model was that the ivermectin concentration used was more than 35 times higher than the maximum plasma concentration after oral administration of the approved doses or therapeutic doses. But higher doses may not be necessary. So now they're responding. They're saying higher doses may not be necessary, as some models predict that the lung achieves higher concentration up to 10-fold higher than in the serum. So if you have level 1 in the serum, then lungs would have 10 in the lung tissue. In addition, ivermectin concentration in blood may not reflect the activity of its other metabolites, which might be the active agent. And I would add one more statement, and that is, even when the Cali study says 35 times they used, that doesn't mean you have to give 35 times. Yes, I agree that that study shows it that way. But since then, there have been many studies that have shown therapeutic doses. So that is a good comment here. Then they talk about a study in Colombia. Then they talk about the study in Bangladesh. Remember, this is the study by Dr. Alam in Bangladesh. I still admire Dr. Alam, that he was one of the early doctors who actually created a study, not only used it. For example, I started using it. He actually created a study out of this after Cali study. So he became the groundbreaking guy, person, doctor to take us further. Then they talk about Dr. Eli Schwartz and team. One may wonder about the public health benefit of treating mild patients, since shortening of the period of relatively mild symptoms may not merit a mass drug administration of the ivermectin to the large population of non-hospitalized patients. then he responds to this and says, however, or them, the team, in inducing faster viral clearance and therefore reducing the time until the patient reaches a state of being non-infectious have an extremely important public health impact. Taking the two composite CT values above 30 and negative culture leads to almost 90% non-infectious state at day 4. And this is important once again. If you are reducing the viral load, if you are killing the virus, then you are preventing the patient from becoming long COVID, or you're preventing them from ending up in a hospital, you're preventing them from potentially dying. They cannot write it here because they did not prove it with the data. I can speculate based on what they are showing. So this is not just limited to, hey, we shortened the time. This is actually expandable to, we saved the person from long haul and from misery and death. From the public health point of view, it may shorten isolation time, which can serve as a major relief of the economic and social burden. Then they say our study has several limitations. So we should see it before you start seeing people becoming upset and saying this is a problem and that is a problem. And I wanted to give you a context here. This is an off-the-record discussion that I am revealing it, I think, for a benefit. And because of that, hopefully Dr. Schwartz and other doctors involved in the discussion will not mind. So I was in a discussion with Dr. Eli Schwartz and some other doctors in which we were talking about the studies with ivermectin, and Dr. Eli Schwartz made a comment saying, hey, we may need more studies. To which another doctor said, Eli, this is the statement that WHO-like folks are taking. They are intentionally creating the seed of mistrust on the current studies. We think we have enough data. But my takeaway was that Dr. Schwartz had some more exploration to do. So if you keep that in mind and then see he has a study, then you would be kind of confident that he would do it with all observation, with suspicion, with trying to make sure that it shows something. And if it does show, then he would come out and say the study shows a result. This is the importance of this study. And my apologies to spilling some off-the-record beans. So our study has several limitations. First, the sample size was relatively small and was designed to look for differences in viral load, but not for clinical deterioration and prevention of hospitalization. So they said, we did not look at that. And so that is not the data point we are offering. The second limitation was that the drug therapy was not physically observed by investigation. So the limitation is, if let's say I'm a patient who's taking the medicine, they would call me and say, hey, did you take the medicine? So if I am not compliant and I'm just lying, then they don't know. So this is a limitation. Again, I don't think that happened, but they take that as a limitation. Finally, our study was conducted among mild, non-hospitalized patients, and therefore the results cannot be applied to a more severe or immune-suppressed population. This is their limitations. The strength of our study was its double-blind structure with more substantial outcomes at a cycle threshold that was lower, such as CT values and culture viability. That is really important. In conclusion, our study strongly supports the notion that ivermectin has anti-SARS-CoV-2 activity. I love this. This is amazing. And here is a study, and having Dr. Schwartz come to this conclusion with his team is a very important outcome. And of course, I'm going to request him if he can join us at some point. So with this, I'm going to stop here. Please remember, tomorrow we would have Dr. Daryl DeMello from India, who has now treated 4,000 to 6,000 patients. And he would be with us tomorrow at 9 o'clock in the morning, so that it is a suitable time for him in India. I think in India, it would be evening 9 or 9:30. So please be kind that it would not be 6, it will be 9 in the morning tomorrow. So with this, I'm going to stop now. Please like, subscribe, and share. This is an important one. Like, subscribe, and share. And if you would like to support this work as well, there are 3 links in the description. One, if you don't like the PayPal, then you can buy me coffees. You can become a patron, or you can use PayPal as well to support this work. With this, thank you very much, and I'll join you again in a few minutes for a chit chat. Thank you. Bye-bye.